This has been great discussion, and I think we've talked a lot about different topics and new therapies, and we're really excited about them. I want to give the panel an opportunity to have some concluding remarks. Nizar, should we start with you? Just a two-sentence comment on what you think the state of the art is.
I would like to thank you for moderating this very lively debate.
It was fun.
I'd like to thank my colleagues for their valuable input. I always learn when I go to these activities. I think it's good news for our patients. I think we are witnessing a revolution in biology, and I think through partnership with industry, academic centers, finally we think we are on the brink of really curing some of the cancers that have been very tough to cure. So I think the excitement is obviously with immunotherapy, with the immune checkpoint inhibitors. We discussed about, nivolumab at second place, and what other target agents can compete in that space. But it is very possible, as Carlos mentioned, some of these combination immune checkpoint plus target agents, such as PD-L1 blockade with axitinib, for example, avelumab plus axitinib phase 2 trial that's about to start, or the one that's already completed, the MPDL32A, atezolizumab plus bevacizumab. If these two trials or the EP-nivolumab if any of these or all of these are positive, then we are looking at a changing paradigm in the first-line therapy. But I think my view is in the next 3 to 5 years, there is still a role for target agents to be played. I do not think immune checkpoint inhibitors, whether they're a combination of two immune checkpoint inhibitors or an immune checkpoint inhibitor plus a target agent, will replace and will be the therapies for all patients. I think drugs such as pazopanib, sunitinib, and other target agents, even mTOR inhibitors, will still have their place for our patients. I think the key is, as Carlos mentioned, is to try to hopefully understand who are the patients who are best treated with a particular therapy. And I think maybe in the next few years, we will finally have biomarkers that can help us select and guide our therapies for our patients.
Paul, what are your concluding comments?
Well, I think just standing back, we've taken a disease that was untreatable for most patients. In other words, most patients did not have benefit from our interventions. And over the last decade or so, we're now in a situation where most patients do have benefit from our interventions. But the current reality is that that benefit is not durable for the vast majority of our patients. And we're just at a point where we may be able to use immunotherapy either alone or in combination with other immunotherapies or with targeted therapies to switch that and take a population of patients and give them durable benefit. And so I'm very excited at the moment. I think there will be a group of patients who are going to have long-term durable benefit. And I think the goal for us is no longer simply palliation. The goal for us is trying to ensure that our patients die from things that are other than their kidney cancer.
Susanne, what about yourself?
Well, I do think that these days are really exciting days. I was tremendously excited by the latest trials. At the same time, I realized that we're still far away from curing our patients. And what it comes down to is that we really have to spend an enormous amount of money at this moment to try to dissect patients, the host characteristics, the characteristics of the tumors, and also to spend a lot of time on really finding biomarkers that will enable us to dissect the patient population into subgroups that are truly different groups, and then try to develop the targeted therapy for those groups and cure them, of course. And I'm afraid that we're still quite a long way. That's going to take some time before we will reach that. And I fully agree that we have to put more investigations into the material, the CTCs, the tumor-free DNA, cell-free DNA, etc. But it's extremely expensive, and it has to be done in a very, very meticulous way in qualified laboratories. So it's not that easy.
Carlos, do you have anything to add?
I think that I agree with all the comments. Thank you very much for moderating. Thank you all for all your comments. I think that we should consider ourselves very lucky to be witnessing this era in the management of kidney cancer, particularly metastatic kidney cancer, in the sense that we have been able to, over the very last few years, seen an enormous array of different alternatives that actually makes, like Paul was saying, improvements, significant improvements in the outcome of our patients. However, we need to realize, like you were saying, Susanne, that we're not curing these patients yet, okay? And in order to change the paradigm and move forward, I think that we need to be both creative and clever. We need to stimulate putting patients in clinical trials, but clinical trials that are not necessarily the same as we have been conducting so far. We need to be more conscious of biology, and we should try to stay away from just picking the drugs off the shelf and giving them to the patient. We need to put rational biology in the future development of this area.
Yeah. That's excellent. So thank you very much to our panel. We have a very international panel here, and it's been a pleasure to chair it. I'd also like to thank all the patients and all of the investigators around the world who have really dedicated their time to these clinical trials and investigations, because without them, we wouldn't be here talking about all of this. And so hopefully the next time we meet again, kidney cancer will have advanced a lot again. Thank you very much.